Bismillahirrahmanirrahim. Dear students, the topic of today's lecture is a logical approach in the diagnosis of inflammatory dermatosis. I gave this lecture at the start of my lectures during Corona lockdown, but at that time I did not record this lecture. So I considered it appropriate to again deliver the lecture and this time record it so that you can see this lecture again and again. I would say that this lecture is the lecture which you should take first, and after that, you should take my lectures on independent inflammatory dermatosis like lichenoid dermatosis or psoriasiform dermatosis or granulomatous or vesicobullous dermatosis. So all those lectures will come after this introductory lecture. So the topic of this lecture is a logical approach in diagnosis of inflammatory dermatosis. What is the logical approach? I will explain this in this lecture. Before I start my lecture, just for your remembrance, this is the normal histology of the skin, comprising of the outer layer that is stratum corneum. Then the layer is stratum lucidum, which is present on palm and soles. The third layer is stratum granulosum. The fourth layer is stratum spinosum, which comprises most of the epidermis. Then the basal layer, which is not polygonal, rather these are the columnar cells. And then after the basal layer starts the dermis. The dermis comprises of two portions. The papillary dermis is the portion which is immediately in vicinity of the epidermis. And here the collagen is a little compact. Then the reticular dermis, where the collagen is rather loosely attached, loosely disposed as compared to the papillary dermis. Now, this is the approach to identify different inflammatory patterns. The first is the tissue reaction patterns, and number two is the distribution patterns of inflammatory infiltrate in the dermis. So, almost all the inflammatory dermatoses will definitely lie into these two patterns, either the tissue reaction patterns or distribution patterns of inflammatory infiltrate in the dermis. As far as the tissue reaction patterns are concerned, Whedon, which is a very popular textbook of dermatopathology, uses 6 major patterns. And you should all remember these 6 major patterns. And remember, these 6 major patterns are according to the dermatopathology or histology, not clinical. This is not a clinical classification. It's a histopathological classification. The first of the reaction pattern is lichenoid dermatosis. The second is psoriasiform dermatosis. Third is spongiotic dermatosis. Fourth is vesicobullous dermatosis. Fifth is granulomatous dermatosis, and sixth is vasculopathic dermatosis. Almost 80% of inflammatory skin conditions lie into either of these 6 patterns. The 20% which are left will be categorized in the second category, which I will be discussing later. So just remember that these 6 major histopathologically reaction patterns will be covering almost 80% of the inflammatory skin condition. So discussing these patterns one by one, the first is the lichenoid or interface dermatosis. By interface dermatosis, you should all understand this thing. There should be a complete loss of basal cell layer. This is called as the basal cell liquefactive degeneration. You cannot see a columnar layer here. Rather, vacuolated cells are visible at the basal layer. Along with the basal layer, the melanocytes are also broken or disturbed, as a result of which, with the loss of basal layer, there will be colloid bodies formation, which are the necrotic keratinocytes, and pigmentary incontinence in the dermis. So if you see in any histological pattern, a loss of basal layer with vacuolation, pigmentary incontinence, and colloid bodies, then these changes are called as interface changes, and the dermatoses which is associated with these interface changes will be called as the interface dermatitis. And what are the different interface dermatitis? All the lichenoid dermatoses are interface dermatitis. What are the lichenoid dermatoses? I will explain in the next slide. Other interface dermatitis include erythema multiforme, Stevens-Johnson syndrome, and TEN, lupus erythematosus, both DLE, SLE, and subacute LE, poikiloderma, and in diseases like pityriasis lichenoides chronicus and pleva. This is a dermatomyositis. If you take a biopsy from any of the lesion of dermatomyositis, or for example, poikiloderma, the first and foremost histological finding will be an interface dermatitis. Lichenoid dermatosis. Lichenoid dermatosis is characterized by basal cell degeneration, that is the interface dermatitis, plus a band-like lymphohistiocytic infiltrate in upper dermis that is hugging or obscuring the dermoepidermal junction. So the lichenoid dermatosis comprises of two closely related histopathological findings. The first one is an interface dermatitis, and second one is a band-like lymphohistiocytic infiltrate. So with this statement, I can say that all the lichenoid dermatoses are also the interface dermatoses. But all interface dermatoses are not lichenoid, because for a lichenoid dermatosis, in addition to the interface change, there has to be a band-like lymphohistiocytic infiltrate. Most of the skin conditions which are known by their first name of lichen are associated with lichenoid dermatosis. That is, these conditions will have basal cell degeneration and a band-like lymphohistiocytic infiltrate. What are these conditions? They include lichen planus, lichen planopilaris, lichen striatus, lichen nitidus, ashy dermatosis or lichen planus pigmentosus, and fixed drug eruption. For detailed discussion of all the lichenoid dermatoses and their histopathology, please refer to my lecture on histopathology of lichenoid dermatosis. Lichen planus. The second reaction pattern is the psoriasiform pattern. Psoriasiform or epidermal hyperplasia is the hyperplasia in which there is regular elongation of reti ridges. Please don't confuse psoriasiform pattern from psoriasis. Although all psoriasis are characterized by this psoriasiform change, but in addition to this change, psoriasis will be diagnosed by the presence of confluent parakeratosis, that is parakeratosis from one edge to through the other edge of the biopsy, along with Monroe abscesses. So if we talk about psoriasiform pattern or psoriasiform hyperplasia, it means that thickening of stratum spinosum to more than 15 cell layer thick. And different conditions which are characterized by psoriasiform hyperplasia include psoriasis, prurigo lichenification, keratodermas, epidermal nevi, seborrheic keratosis, warts, and molluscum contagiosum. These are different patterns of psoriasiform hyperplasia. Here it is important to differentiate between regular and irregular psoriasiform hyperplasia. If the reti ridges are of equal length along with a long dermal papillae to form a striking undulating pattern, this is a regular psoriasiform hyperplasia which we see in psoriasis. In contrast, if this kind of hyperplasia is irregular, The retinages are of irregular size and they are irregularly placed, then this pattern is seen in chronic or acute or chronic eczemas. For a detailed lecture, for a detailed account of all the psoriasiform hyperplasias, please refer to my lecture previously given. Then the third pattern of tissue reaction is the spongiotic pattern, which is also called as eczematous pattern. This is characterized by intraepidermal or intracellular edema, which may form microscopic or grossly visible vesicles. Spongiosis is the intercellular edema. These are the retinages and they are connected by the desmosomal junction. Usually, the cells are so close to each other that the desmosomal junctions are not visible. But because of an inflammatory skin condition in which water accumulates between the cells, the presence of the water separates the cell from each other, resulting in a histological condition that is called as spongiosis. And in spongiosis, these desmosomal junctions, they become more obvious. Another finding which is associated with this spongiosis is the entrance of inflammatory cells into the epidermis, because now there are spaces in between the keratinocytes and inflammatory cells. For inflammatory cells, it becomes easy that they can enter into the epidermis. This phenomena of entering the inflammatory in cells into the epidermis is called as exocytosis. There are various conditions in which the main histological finding is spongiosis, and the prototype condition is eczema, and P. rosea is another form of eczema, then superficial fungal infections, lichen striatus, insect bite reaction, prurigo nodularis, polymorphic eruption of pregnancy, acral papular eruption of childhood, which is the Gannett-Crosty disease, and parasorasis. So all these diseases are characterized by spongiosis. For a detailed description of the diseases characterized by spongiosis, please refer to my lectures, which is previously given. There are few diseases that are typically associated with spongiosis and eosinophilic exocytosis and eosinophilic infiltrate in the dermis. There are three main conditions: atopic dermatitis or other contact dermatitis, insect bite reaction, and drug reaction. In addition to this, polymorphic eruption of pregnancy is also characterized by eosinophilic spongiosis. Then, very interesting, there are few diseases that are associated with spongiosis along with neutrophils. And the first disease here written is pustular psoriasis. So if anybody says that there is no spongiosis in psoriasis, this is not right, because spongiform pustule of Kogoch, which is one of the characteristic histopathological finding of psoriasis, is characterized by spongiosis in superficial layers of the epidermis along with the neutrophilic infiltrate. In addition to that, acute generalized exanthemic pustulosis is characterized by similar change, that is a large spongiform pustule of Kogoch. Dermatophytosis is also characterized by neutrophilic spongiosis, then Pedras dermatitis. Seborrheic eczema is the only eczema that is characterized by neutrophilic infiltrate and infantile acropustulosis. The fourth pattern, which we should all remember and recognize, is the presence of a vesicle or a blister in the skin biopsy. The blister can be at subcorneal, it can be intraepidermal, it can be supravasal, and it can be subepidermal. So once a blister is seen, it is mandatory that you should determine the anatomical location of that blister. And second thing to note is whether the blister contain an inflammatory infiltrate or it is cell poor. If it is an inflammatory infiltrate, then try to find that which are the cells that are predominantly seen within this inflammatory infiltrate. And many a times for diagnosis, we have to resort to immunofluorescence, especially autoimmune blistering disorders. So this is a subcorneal blister. You can see that underneath the stratum corneum, there is a blister cavity and most of the epidermis is lying at the floor of the blister. So subcorneal blister is seen in pemphigus foliaceus, in subcorneal pustular dermatoses, in pustular psoriasis, in bullous impeti. This is subcorneal pustular dermatosis. You can see very superficial and flaccid blisters. Flaccid because subcorneal blisters or intraepidermal blister will always be flaccid, easy to burst. Then this is an intraepidermal blister seen mainly in eczema and viral infections. These blisters are created by extensive spongiosis resulting in disruption of the keratinocytes and formation of vesicles. This is acute irritant dermatitis, clinically and histologically associated with blisters. Pemphigus foliaceus. Suprabasal blister. Suprabasal blister is characteristically seen in pemphigus group of diseases, in which the blister is seen on suprabasal and basal cell is seen attached to the dermal papillae, but individual basal cells are also separated from each other and they are individually attached as like tombstones. So pemphigus group of diseases include pemphigus vulgaris, paraneoplastic pemphigus, Hailey-Hailey, Darier's and Grover's disease. These all pemphigus group of diseases is characterized by acantholytic cells within the blister cavity. This is pemphigus vulgaris. So if a blister is subepidermal, then it is must that you should determine that which are the prominent inflammatory cells present in the blister. And in this case, it is neutrophils. So neutrophil rich subepidermal blistering is seen in this case, it is eosinophils. So eosinophil rich subepidermal blistering is seen in pemphigus and in pemphigoid, in herpes gestationis, and in a variety of epidermolysis bullosa acquisita. Then a subepidermal blister that is associated with neutrophils is seen in linear IgA disease, in bullous SLE and Sweet syndrome, and sometimes in epidermolysis bullosa acquisita. This is linear IgA dermatosis. Dermatitis herpetiformis is not associated with large subepidermal blister. Rather, it is associated with papillary tip microabscesses or small vesicles at the tip of the dermal papillae with neutrophilic infiltrate. This is DH. Then there are many inflammatory conditions in which there is a tense blister, but histologically there is no inflammatory infiltrate. So such kind of blisters are seen in epidermolysis bullosa, both the inherited form and acquisita, porphyrias, burns, toxic epidermal necrolysis, suction blister, bullous amyloid, cryotherapy, and diabetic bully. If you don't find psoriasiform pattern, interface pattern, spongiotic pattern, or any blister, then you must look into the dermis to find any granulomas. And if granulomas are seen within the dermis, then it fits into the fifth pattern, that is the granulomatous pattern. And in skin, there are four major classes of granulomas: the sarcoidal granulomas, tuberculoid granulomas, necrobiotic granulomas, and suppurative granulomas. Sarcoidal granulomas. Sarcoidal granulomas are characterized by a few special findings. That is, the granulomas are discrete, and each of the granulomas, they are discretely placed and separated from each other. The giant cells within the granulomas are mainly foreign body type giant cells, in which the nuclei are irregularly placed within the cytoplasm. And the third feature is the presence of paucicellular infiltrate or very slight or light inflammatory infiltrate, and that's why these granulomas are also called as the naked granulomas. The foreign body granulomas are sarcoidal in nature. So the sarcoidal granulomas are not only seen in sarcoidosis, but also seen in foreign body reaction. Then the second type of granulomas are the tuberculoid granulomas. Tuberculoid granulomas are again characterized by three features. The first is that the granulomas, they are not discrete, rather they are merging with each other. The main inflammatory cell is the Langhans type of giant cell, in which the nuclei attach in a horseshoe shape, and it is characterized by dense surrounding inflammatory infiltrate, comprising of lymphocytes, plasma cells, and histocytes. Caseation necrosis may or may not be present. There are several diseases that are characterized by tuberculoid granulomas. The first is the skin tuberculosis, then different tubercles, tuberculoid leprosy, leishmaniasis, rosacea, perioral dermatitis, acne agamata, and Crohn's disease. The third type of granulomas are suppurative granulomas, which are characterized by neutrophilic abscesses surrounded by the granulomas. Usually, these kind of granulomas are seen in two causes. That is the deep fungal infections, and number two are the atypical mycobacteria. And both the two infections are seen within this suppuration. This is a deep fungal infection. There are non-infectious types of suppurative granuloma, which is seen in superficial granulomatous pyoderma gangrenosum. Fourth type of granulomas are the necrobiotic granulomas, which are characterized by necrobiosis surrounding the necrobiosis. They are palisading granulomas. And such kind of granulomas are seen in granuloma annular, necrobiosis lipoidica, granuloma multiforme, rheumatoid nodules, and actinic granuloma. The sixth pattern, that is, if you don't find psoriasiform, spongiotic, or lichenoid, or vesicobullous, or granulomatous, but you find pathology in the vessels, then it would fit into a vasculopathic pattern. The pathology can be in small blood vessels, it can be in medium or large cell blood vessels, it can be a different kind of inflammatory infiltrate. But if the pathology is involving the blood vessels, it would be called as a vasculitis or vasculopathy. Vasculitis is a term applied to inflammation and some form of vessel wall damage, necrosis or fibrinoid chain, plus minus extravasated RBCs and neutrophilic dust. So these there are three blood vessels in this view, and these three vessels are having fibrinoid necrosis of vessel wall, dense inflammatory infiltrate surrounding an intramural, and with predominant neutrophils. So these are the predominant neutrophils. You can see the red blood cells extravasation and the nuclear dust, which is actually the derived from the different lobules of the nuclei of neutrophils. So after completing the 6 tissue reaction patterns, which I have told you will be covering 80% of inflammatory skin conditions, rest of the 20% of the inflammatory skin conditions will fall into either of these four patterns of distribution of inflammatory infiltrate in the dermis. And this is again taken from the histopathology book of Whedon. These four inflammatory patterns are superficial perivascular, superficial and deep dermal perivascular, folliculitis and perifolliculitis, and paniculitis. Superficial perivascular inflammatory pattern. This kind of inflammatory pattern is usually accompanied with spongiotic, psoriasiform, or lichenoid pattern. That is, the psoriasis is characterized by a superficial perivascular infiltrate. Eczema is characterized by superficial perivascular infiltrate. So the superficial perivascular infiltrate, if it is seen along with a spongiotic, psoriasiform, or lichenoid dermatosis, then frankly it carries no special significance in the diagnosis. However, there are certain reactions in which this superficial pattern of inflammatory infiltrate is quite important, as there are the other findings are not very significant, like in drug reactions. The main histology is of superficial perivascular inflammation with eosinophils. Similarly, the viral exanthems, which is usually characterized by a faint superficial perivascular lymphocytic infiltrate. And same is the case with chronic urticaria. This is erythema annulare centrifugum, and it is characterized by superficial and deep perivascular infiltrate in a coat sleeve pattern. Other kind of annular erythemas are also characterized by the same pattern. This kind of superficial and deep, dense perivascular inflammatory infiltrate is also seen in pigmented purpuric dermatosis, and it is seen in polymorphic light eruption, in Jessner's lymphocytic infiltrate, in lupus erythematosus, and insect bite. This is Jessner's lymphocytic infiltrate. Chronic insect bite reaction. Usually there are eosinophil predominance here. Tumid alleles, again characterized by superficial and deep perivascular inflammatory infiltrate with some periadnexal and intradermal mucin deposition. Secondary syphilis is characterized by epidermal hyperplasia and dense perivascular plasma cell infiltrate characterized by endovasculitis, that is blocking or obstruction of the vessel lumen. The third pattern of inflammatory infiltrate distribution is either distributing surrounding the hair follicles or in the spaces between the hair follicles. If an infiltrate is seen surrounding a hair follicle and within the hair follicle, it is called as the folliculitis. And if it is seen surrounding the hair follicle, it is called as the perifolliculitis. So the folliculitis can be infectious and non-infectious, and it could be superficial and deep. One of the pattern of folliculitis is a fruncle, in which whole of the follicle is involved by the inflammatory infiltrate, which is acute. And carbuncle involves 2 to 3 adjacent follicles. This is a folliculitis, that is the neutrophilic infiltrate is invading whole of the hair follicle. Demodex folliculitis is characterized by presence of Demodex mite with surrounding inflammation. Carbuncle is characterized by acute inflammation involving 2 or more adjacent follicles. Folliculitis can be infectious and non-infectious. Infectious causes of folliculitis include Staph aureus, Pseudomonas, gram-negative folliculitis, Pitrasosporum folliculitis, perifolliculitis capitis, acne vulgaris, and rosacea. While non-infectious type of folliculitis may be due to a physical trauma, pseudofolliculitis, contact with mineral oil and tars, perforating folliculitis, and follicular mucinosis. Perifolliculitis. Perifolliculitis means inflammation surrounding the hair follicle. And the perifolliculitis is characteristically seen in various different conditions, like in keratosis pilaris, in follicular eczema, eosinophilic folliculitis of Fuji, Mazuki's granuloma, lichen planopilaris, discoid lupus erythematosus, alopecia areata, and traction alopecia. So one of the finding of all these clinical conditions is the presence of perifollicular infiltrate. In addition to this perifollicular infiltrate, there are other findings which will be characteristic of such condition. For example, in KP, there will be follicular plugging. In follicular eczema, there will be follicular spongiosis. In Majoki granuloma, there will be eosinophilic, there will be PS positive spores within the hair follicles. In DLE, there will be perifollicular and periadnexal infiltrate along with the interface change. So there are different other patterns which would be seen in perifolliculitis. Then the last pattern of inflammatory infiltrate is the pattern in which the infiltrate is present within the subcutaneous fat. And there are two patterns: either the infiltrate will be present along the septal blood vessels, or the infiltrate is present between the fat lobules. So septal panniculitis is characteristically seen in erythema nodosum, while the lobicular panniculitis is seen in enzymatic or pancreatic panniculitis, alpha-1 antitrypsin deficiency, subcutaneous fat necrosis. Mixed panniculitis, in which both the septal and lobular changes are seen in lupus erythematosus profundus and infective panniculitis. There are certain panniculitis which are associated with vasculitis as well. These include polyarteritis nodosa, thrombophlebitis, and erythema indurata. These are panniculitis which is characterized by a puckered site of sort of scarring, and initially there will be subcutaneous nodule that will be thick and attached to the dermis, to the subcutaneous fat. This is a pattern of septal panniculitis in which the inflammatory infiltrate is seen within the surrounding the septal blood vessel. Then this is a lobular panniculitis in which the inflammatory infiltrate is invading the subcutaneous fat lobules. So for the detailed description of panniculitis, please refer to my previous lecture. So I would like here to conclude that there are 10 patterns of inflammatory dermatosis, and these patterns cover all the inflammatory dermatosis. 80% of the inflammatory dermatosis will lie into this major tissue reaction pattern, which are the lichenoid or interface dermatosis, thoraciform dermatosis, spongiotic dermatosis, vesicobulous dermatosis, granulomatous, and vasculopathic. And 20% of inflammatory infiltrate will fall in these minor reaction patterns, which are either superficial perivascular infiltrate, superficial and deep perivascular infiltrate, folliculitis and perifolliculitis, and panniculitis. So I would like you all to remember these 10 different patterns. And whenever you see a slide of inflammatory dermatosis, always try to fit your diagnosis into any of these 10 patterns. If you locate that if the disease which I am seeing is, for example, having interface dermatitis, then your search will be limited to those disorders which present as interface dermatitis. Similarly, if there is thoraciform hyperplasia, then you know that what are the conditions in which there would be a thoraciform hyperplasia. Similarly, if you see spongiosis, then it would be easy for you to diagnose that what are the conditions which are characterized by spongiosis. Similarly, granulomatous, vesicobulous, or vasculopathic. So if you are able to classify your inflammatory skin condition into any of these patterns, then the final diagnosis or the definite diagnosis of that histology becomes very, very easy. Thank you all for patient listening. Khuda Hafiz.